So it's 9 a.m. already. Today this is the first time we got the speaker from Singapore come here to share some of the knowledge. I would like to introduce the Dr. Roger Tan. He's you can see he's the director of the Renal Kidney Clinic in Singapore. Yeah. We have to say thank you to the Parkway organization. They bring him to us. Yeah. Now today he will do the presentation. We don't do any translation. I ask him to speak slowly for everyone can understand. Okay. After finish the presentation, if you have any question, okay, we can connect together. Yeah.
So, good morning, doctors, ladies and gentlemen. Can hear me? Sorry, I'm having a bit of flu. Is this speed of English okay? Can understand? At any point, if I lose you or you lose me, please let me know. As you can see, I am a nephrologist. Nephrologist, we are kidney physician. There are two things that I love when I do nephrology. Most of you are doctors. Most of you want to treat patients. Most of you want to save life. That's why we want to be doctors. But why these two areas I especially like it, not just you save patients, you literally change the life of the patients. And these two areas I'm referring to is transplant. I subspecialize in transplant, simple transplant, difficult transplant. Why? Because after transplant, the life of a patient improves. They are back to normal. The family quality also improves. The other areas that I love is ICU. ICU is very stressful. It's very taxing. For those who run ICU, you will be caught almost every second, every minute in the middle of the night while you're sleeping. It can be very stressful and disturbing to family. But if you do it well, you save life. You don't just save your patient's life, you save the whole family. And I find all these two areas very rewarding because you literally give a patient and family a second chance. Today, I'm going to talk on three areas. These three areas. As nephrologists, we deal with acute kidney failure in ICU. I'm going to introduce another, I should say, new things using dialysis modality to treat sepsis. Everyone is familiar, sepsis, antibiotic. But I'm going to show to you this method of approach, we are missing out on a big mechanism of sepsis causing mortality. And seems like dialysis treatment may be the way to go. The last thing, I'm not a cardiologist, but I run ICU, so I'm going to introduce ECMO. Many of you may be familiar with ECMO. It's to share with you how we use ECMO in our service in ICU to save life. So this is where I practice. Many are not familiar with this place. This is Gleneagles. It's one of the big hospitals under Parkway. Many of you are more familiar with Mount E Orchard, Mount E Novena. I also go there to help to run the ICU. So for nephrologists or even for intensivists like some of you, you run everywhere. We don't station in one place. I go to all hospitals. Whenever there's a service, there's a requirement, I go there. So the first thing I'm going to touch on is acute kidney injury in ICU. What do we do? I've mentioned already in ICU, this is what we do as an FAU. This is what we do on a daily basis in ICU. Balancing electrolytes, acid base, fluid balance, and the last thing is the new thing that I'm going to mention. Doing dialysis is easy. Who has initiated dialysis in your hospital before? Anyone initiated? Doing it is easy. Actually, you just get the machine, hook it on. I always say dialysis is like laundry service. You bring the washing machine there, finish, go home. Doing that is easy. Difficult part is when to start, what machine to use. These are the two difficult questions, and up to now, there is no correct answer. Just to take you through, first case, middle age, diabetic, chronic kidney disease, baseline creatinine about 2.1. So already not too good kidney. Admitted for pneumonia. Went down to ICU because of septic shock. The BP very low, started inotrope. On day 1, you'll notice that the urine output from 80 mL per hour to 50 mL per hour. Whenever you look at urine output, always must ask what is your estimated daily input. Then you know whether can it be balanced. So looking at this patient, daily input is about 2 liters. If assume that she has 50 mL per hour, probably one day urine output about 1.2, plus the ventilatory loss, involuntary loss, probably just nice. 50 mL should be enough. IO should be quite well balanced. So always ask about the input when you see a patient in ICU. After one day, the creatinine start going up, 2.1 to 2.4. As expected, potassium will be an issue. As expected, metabolic acidosis set in. Question to you guys, at this point, who will start dialysis? Creatinine 2.1, 2.4. Like I say, there's no right or wrong answer. Who would have started dialysis here? Show of hand. Who will not start? The rest, call the nephrologist. So start or not start, the reason for starting, I think, is because of acidosis, hyperkalemia, worsening of kidney function. Not wrong to start. Say we don't want to start. This is what's going to happen. As the days goes by, urine output start dropping. The input is still the same, 2.5 or even slightly more, because now more and more inotropes goes in. Giving IV sodium bicarbonate is fluid there. There's more medication to correct that acidosis, metabolic, electrolyte imbalances. So creatinine now has gone up to 2.9. Still hyperkalemia, acidosis. Urine output, I stress again, has dropped. 80, 50, 20. Who will start now? She's quite young, 60 plus. Who will start dialysis now? Who will not start? So from the way I question you guys, you probably, going to start. Who will not start? All we want to start. For those who say, I don't want to start, my question to you is, when is the right time to start? I've gone around talking to doctors about ICU. I'm very happy that all of you agree to start, because there's a big group of doctors has this idea, start dialysis, the criteria is like chronic kidney disease. They've forgotten this is ICU. The CKD stage 5 start dialysis doesn't apply here. So some will say, let's wait until creatinine 6, then we start, because this is CKD stage 5, justified to start dialysis. I think you guys are correct. This is acute kidney injury. You cannot apply the CKD criteria. Once you see that the urine output start dropping and you have problem despite 2-3 days struggling with medication, rightfully so, please start the dialysis. And urine output is the most sensitive marker. Not creatinine, not electrolyte, it's the urine output. Once you see urine output start dropping, you know you are in trouble, unless you expect the patient to turn around within the next 24, 48 hours. If not, I always prefer, that's my opinion, start early. So as expected, drop. By now, almost end uric. I think by now, everyone will say start. You wait some more, family will make noise. Or they may get another doctor to come in. Second case, young man, undergo a simple laparoscopic cholecystectomy. Post-op sepsis, went into septic shock again. Baseline creatinine pre-op 0.8, now 1.3. Gram-negative sepsis, started double inotrope. In fact, because of it's a gallbladder, he's diabetic, it's not diabetic, gallbladder, we just give antifungal. just to make sure we don't miss out on anything. And you can see the urine output has dropped from 120 to 30 mils per hour. Creatinine only gone up 0.8 to 1.3. But in severe acidosis, start, don't start. 1.3 only creatinine. 1.3, who dares to start? My question to you, who dares to start? I don't dare, honestly, I may not dare. Because 1.3 is not so bad. But it's the acidosis that's killing her, killing this patient. If you compare to just now 2.8, bicarbonate 19, this is only 1.3 and the acidosis is very bad. When you see such case in someone with hepatobiliary, you must suspect pancreatitis. You must suspect hepatic involvement. So I agree, if anyone is ready, go ahead and start. Because I don't expect him to turn around within the next few days. So why we like to hold off dialysis? If you look at meta-analysis now, systemic review, start dialysis, don't start dialysis. The data, the evidence, the conclusion is your choice. Start, don't start, depending on which study that you do. Some will say no added benefit, some will say create more risk. So up till now, there is no consensus. Some conservative doctors will still want to try all medical therapy until patient dies first, or you have no choice. Then you start. I prefer to start early. I prefer always to start early because dialysis will take care of all these things. Imagine the nurses keep calling you. Fluid balance. You increase diuretic. Not working. At night, they also call you. I think for logistics, starting early, not just make the patient safe, make the patient safe, but also make your life better. That's my humble opinion. Lasix has been shown, furosemide has been shown actually to increase the mortality. Diuretic has been shown to increase the mortality in ICU patient. Reason behind it gives doctors a false sense of security. I give diuretic, urine come out, kidney is recovering, which is not true. Totally not true. It just forces out water, that's all. It does not treat the electrolyte imbalance, so don't fall into that trap. Similarly, for sodium bicarbonate to correct metabolic acidosis, it has been shown to increase mortality in prolonged hospitalization. So this is something that we are doing every day, but not knowing the evidence behind and delaying dialysis treatment. And some studies have shown by delaying dialysis, you actually increase the hospitalization stay. So these are all the reasons why I think we should start early. But the most important reason, I think the most important marker for yourself on a daily basis when to start dialysis is what I pointed out here. If you see your patient and you sense that over the next few days, he or she is not going to improve despite maximum therapy, please start early. Because 3 days later, he'll still be the same or worse off. Better start early. Of course, if it's due to a sudden hypotension, you fluid challenge, you recover 24 hours, by all means you can wait. But most of your ICU patients are not like that. It's a progressive decline. And if you don't see any improvement within 48, 72 hours, do start early. And the other reason, the other indication to start early is the family. The family, some of them you may have encountered, they only tell you one thing. I don't care what you do, save him. This is a clear-cut indication we must give the patients the best, and that includes dialysis. Now, when to start, I've gone through it. What modality to start? Sorry, you may not see this. Intermittent hemodialysis, that's your regular dialysis. CRRT, many are familiar with. How about SLED? Do you guys use SLED here? Yeah, so for those who are not familiar, intermittent dialysis, CRRT, SLED is a hybrid in between. 4 hours, 24 hours, 48 hours, 6 to 8 hours. So that's SLED. Which one to choose? Sad to say, consensus, meta-analysis, systematic review cannot give us an answer. But I definitely believe CRRT gives us added benefit that intermittent dialysis cannot. Why you chose CRRT is because patient hemodynamically not stable. BP is supported. If you do intermittent dialysis, the blood flow is too stressful on the cardiovascular of the patient. Blood pressure will drop. So that's the reason why we do CRRT. Another condition that CRRT always give a better advantage, those with intracranial lesion, be it edema, bleed, tumor. Intermittent dialysis, because of the fast shift in electrolytes and urea, will predispose patient to cerebral edema. It will make an intracranial bleed worse. So these are the situations where CRRT will not touch the intracranial pressure. That's one indication to start CRRT and not intermittent dialysis. How about SLED? In general, they are about the same. Some centers in states only do SLED. They don't do CRRT because they don't want to invest in the machine. SLED is good, but one take-home message, if you want to do SLED, it must be a 6 hours, 8 hours. Doing a 4-hour SLED is like doing a 2 hours intermittent dialysis. Not effective at all. So it must be a 6 to 8 hours. Then maybe you will achieve the same outcome as a CRRT. So for those who are not familiar with SLED, when we do intermittent dialysis, most of us are running a speed of 250 mils per hour, the blood flow. When we do SLED, we are running at 150. So it's a slower speed. It's just like washing machine. When you spin slower, you have to extend the time. Same thing, if you do SLED, you have to extend the time. If not, you will not achieve the clearance that you guys aim for. So this is one of the problems with SLED or intermittent dialysis. Whenever we do SLED or intermittent dialysis, within 6 hours, 4 hours, you will see the fluid withdraw all the water. So how normally it goes, I expect today, next 24 hours, input to be 2.5 liter. Example, I need to do SLED today. How much water to take will depends on what is my expected input and what is my balance I want to achieve. And then you calculate. Most of the time, you take out about 2 liter plus. And this is what's going to happen. You take out 2 liter plus. The next 24, 48 hours, the fluid balance increase again. Then you do the same thing again. Every time you take out such 2 liter, 3 liter of water, you're going to cause the blood pressure to drop. And typically in intermittent or SLED dialysis, the inotrope requirement during that 4 to 8 hours will have to increase. Typically, that's the scenario. That's the thing that I don't like about intermittent dialysis. Every time you have to increase the inotropic support. And I don't know whether have you guys seen the bad side effect of inotropes. I'm quite sure you've seen digital amputation before. All these are known complications due to high-dose inotrope. So this is the thing that I don't like. This up and down in BP. That's why I use, if possible, I always use a CRRT. Typical CRRT machine looks scary, but actually it's a simple model. The only thing that we are interested in is here. All these pipes. What happens in the machine, all these are, at least to me, to the bioengineer is different. But to most of us, this is what we care for. It's a simple setup, looks scary, but it is a very simple setup. Some of the problem with CRRT, clotting. You need to run a circuit for 24 hours, 48 hours, or even longer, 72 hours. And if you are seeing a septic shock patient, DIVC, platelet low, prolonged PT, PTT, you have difficulty to give heparin. You don't give heparin, circuit clotted, blood is lost, money is wasted. So that is always the problem with CRRT, clotting. 2 things to avoid if you want to prevent clotting. Whoever insert the dialysis catheter, please do it properly. If the dialysis catheter is not properly inserted, clotting will sure happen no matter what you do. So the upper, the subclavian, all these areas, IJ, are always better than femoral. Femoral has more clotting. But sometimes in ICU, no more neck veins for you already, so no choice you have to do that. Second thing, if possible, even DIVC, even low platelet, if you can give a little bit of heparin, that will help. 50 units, 100 units per hour, not too much, but that can keep the circuit ongoing. Of course, there are some patients we give such a low dose heparin, still clot, or worse still, start bleeding. What can you do? What do you guys do here? If you're faced with such situation, started CRRT, patient bleeding, circuit keep clotting, may I just ask for those who does ICU's nephrology, what do you normally do here?
I think that the circuit clotting may be the result of embolization, the blood flow. The circuit clotting is the result. Is a result of blood flow. Maybe you have the low blood flow, the more circuit clotting become. Yes, the heparinization. Yes, in this case, you should, you must choose. You should choose patient, not choose circuit. Yes, in this case, the plate only 22 per milliliter. I think that. The heparinization you should use is a low molecular weight heparin. Yes, to prevent circuit clotting. Yes, and you increase the blood flow. You have the stable blood pressure. You increase the blood flow. Yes.
So that is one of the things that you will be troubleshooting. Increase the flow, increase the volume exchange, increase the what we call the PPP. They need to flush the circuit more often and, of course, with or without increasing heparin. That's something that you can do. But sometimes, no matter what we do, every 6 to 8 hours, they have to change the circuit. I'm not sure about the cost here. One filter in Singapore costs $1,000 over. So every 6 to 8 hours, when they keep changing the filter, it's a lot of money. We are quite lucky now. I have this, nephrologists, we like to play. We play with machine. That's one of the reasons why I be a nephrology. Not just I deal with doctors, I play with machine. So we have new machine coming in. Some of you have heard of citrate dialysis? Anyone use it before? So this is something that we can use in those hyperclotter or in those patients who have to change the dialyzer because of clotting. It is the same setting as CRRT. The only added thing is another extra circuit where we introduce citrate. Citrate is a blood thinner. Some of you, if you can remember your younger years where you take blood, you know the blood tube, there's a citrate tube. It's actually an anticoagulant inside. So same thing, we are injecting the anticoagulant inside. The only problem is what happens if this anticoagulant goes into the system. It enters the patient body, it will cause DIVs, you cause the bleeding worse. And that's why to correct that is very easy. All you need is to inject calcium. You inject the citrate in, before it enters the patient's body, you give in calcium, precipitate it, and then it will not enter the system. And there will be tests in between to make sure this citrate is washed out. So this circuit, we have used it for the last 1 year or so. You will be surprised. At the end of 72 hours, never clot. Nobody trouble me at all. So that is one thing that I like. Typically very useful in those patients with heart problem. When they are on multi-anticoagulant, you cannot add some more. The BP is always low. This is something that you may consider. Only contraindication, those with very deranged liver function, because citrate is still metabolized by the liver. So the liver must be of reasonable function before you can start this machine. So that's something for you guys to consider, a new modality for us to start. So that is what we do, and that's what we have been doing. And these two patients eventually, as what you guys have rightly pointed out, don't wait, please start. And both are started on CRRT. And they are quite young. They were quite young, 40 plus, 60 plus, both recovered well, discharged. One life saves, few families members happy. So does CRRT make the difference? Meta-analysis tell us no. Personally, I say yes. You correct the abnormality very early. You make patient recover faster. More important, your life also is easier. You will not be disturbed so many times. Now, I'm going to go on to the second topic, sepsis. All of us deal with septic patient. And our treatment very similar. Nothing that you guys are doing is different from us. Maybe you can say antibiotic different, newer antibiotic, different names of antibiotic. But nothing else changed. Nothing else has changed for the last 20 years for management of septic shock. I'm going to introduce a new modality for some of you who may be interested. Septic shock, common condition ICU, accounts for 50% at least of mortality in all ICU. And usually it's defined by not just sepsis, low blood pressure. It's actually multi-organ failure. So you must have that to diagnose a septic shock. And typical ICU, you see this, a septic shock patient, usually for the doctors and nurses, you have no space to move around. There are multiple machines, there are multiple tubes here and there. To find venous access is difficult because everyone is on medication, etc., etc. And all organs are affected, and as I said, 50% mortality at least, no matter what you do. Statistic is the same. And this is what we have been doing for the last, many years. Nothing has changed. People argue Hartmann's solution may be better than normal saline. People argue lactate solution may be better than normal saline. But to me, it's still fluid resuscitation. If you give enough volume, you should achieve what you want to achieve in majority of cases. Antibiotic, we have newer antibiotic, better and better antibiotic. But I challenge you, many of you will realize in some of your septic shock patients, after a few days, the blood culture is negative, but yet they're still in septic shock. In fact, some of them, the inotropic requirement has to be even more when the culture is negative. So are we missing something? If it's due to bacteria alone, your good antibiotic will kill off all of them. No, it's not. So something is missing somewhere. Inotropes, 2 inotrope, 3 inotrope, 4. If you look at most guidelines, will tell you maybe 2. After 2, it's cowboy land. You can do anything you want. No evidence at all. But this is what we have been doing. Add and add and add. Patient's finger turn blue, toe turn black. Ischemic gangrene happen. And once you have ischemic bowel in ICU, it's game over. You can tell the family prepare. You can delay 1 day, 2 days, but eventually all will die, ischemic bowel. So something that we have been using, but with a lot of complication, and yet the percentage survival still 50%. We are missing something. These are all the antibiotics. Believe me, there are more and more being discovered. Gram-negative, more and more expensive. Very expensive, good for pharmacology, for the pharma company. Does it really improve the outcome? Unless you're dealing with multi-resistant. If not, most of our common antibiotics should be able to wipe out 90% of bacteria. So strong antibiotic, new antibiotic, only selected patients, but not for all. So it may not solve the problem. What is causing the problem is this very important slide. This is where the bacteria is. Once it enters the body, if you remember your physiology, pathology, once bacteria goes into the system, especially gram-negative, it is going to secrete a lot of inflammatory chemicals. Your body will mount a lot of inflammatory reaction against this bacteria. And this is what you're going to see. Once bacteria enter, they are going to secrete a lot of inflammatory markers, especially interleukin-6, TNF. All these are powerful chemo mediators. And these are the ones that eventually cause all the problem. So once you have all these cytokines, IL-6, IL-2, TNF, these cytokines will circulate in your body. Even when the bacteria is dead, the cytokine still stays in your body. And these are the ones that cause all this problem. So it's not surprisingly why you kill bacteria, yet the lung don't recover. Because of the endothelial injury from cytokine release. Not surprising why your ventilator cannot come down, because all your TNF, IL-6 cause vasodilation. You kill bacteria, they are still there. Your kidney is not working, it's not excreting out. It gets trapped in the body, and the septic shock carry on despite culture negative. It is this cytokine which many of us start to believe it is driving most of the death in a septic shock patient. So this is a typical scenario. On off, you will see in your ICU, patient condition worsen, blood pressure drop, then recover again. Blood pressure drop, recover again. Whenever there is a lot of cytokine release, the immunity in the body paralyzed. The body cannot fight the own bacteria on top of the antibiotic. This prolonged cycle can last up to 1-2 weeks or even longer, even when the culture is negative. When we do so-called dialysis treatment or apheresis, the correct word is called apheresis, you are actually washing out this cytokine. It's like dialysis. Dialysis takes care of renal toxin, electrolyte acidosis. Apheresis is like plasma exchange, but I'm targeting the cytokines, inflammatory marker. It is to absorb the inflammatory marker. It's to reduce this cytokine storm, improve the immunity, and give patients the better chance. So, take you through a case, younger. In fact, younger than some of us, 30 plus, came in appendicitis. Undergo a simple appendicectomy, and then post-op septic shock. On double inotrope support, expected gram-negative, given 2-3 gram net cover. After that, culture negative, but yet the reaction still carry on. Oliguric, acute kidney failure, inflammatory markers still high. Anyone want to make a guess or want to manage this patient? You're already in ICU, double inotrope, antibiotic, 33-year-old. What can we do to improve it? So this is what happened over the next few days. Despite all these things, the kidney function goes off. More and more inotrope added. One of the indications for us, like I said just now, to think out of the box, to start things differently, is when the family tell you, I don't care what you do, save my daughter, 33 years old. Okay, since you say that, that's when immunoabsorbent comes in. This is on top of your dialysis treatment. What else can we do to improve the survival? Having said that, this was about 2 years plus ago. In Singapore, immunoabsorbent for sepsis is still not acceptable form of treatment. In fact, I have to apply to Ministry of Health to ask for approval on a named patient basis. So it's not as easy as I give. 2 years ago, I have to apply. It takes about 48 hours to get the approval, which is what we did, we applied. And this is what the immunoabsorbent look like. This is one of the system of the immunoabsorbent that we employ, CPFA. Some of you may have used it before. Some use it for plasma exchange. Some use it for liver toxicity, poisoning. We use this for sepsis immunoabsorbent. It's the same machine. I mean, it looks like the same machine. The only thing different is the dialyzer. It is made out of chemicals to absorb pellets, small pellets to absorb cytokine. Absorb all the cytokine. And the circuit is very similar to, the circuit is very similar to your CRRT machine. So everything comes in as a package. The machine, the dialyzer. All you need is a dialysis nurse, a technician to hook it up to the patient's dialysis catheter. And you're all ready to go. And this is what you see. It's supposed to reduce the IL-6. Very convincingly reduce the IL-6. within the next 10 hours. Inflammatory marker also down. More important, the clinical outcome. When you reduce the inflammatory markers, the blood pressure improve. Inotropic support drop. Lung injury less. So not just theory, clinical improvement. So that's the reason why the Japanese has been pushing and the European country has been pushing for CPFA in a selected group of doctors, among the selected group of doctors. And this is one of the small trials. To do ICU trial, not easy. Because a lot of factors. And some patients, I'm not sure in here, in Singapore or in many countries, to do trial, you need patient's consent. You need hospital consent. Patient already half dead. Family to give consent, impossible. So most of the trial, we are looking at very small numbers. Very small numbers. I understand there are cardiologists here. If you go to any cardio conference and you tell them this is a randomized control trial, people will be laughing off. No way, this is a double digit at most. Small trial. Evidence very weak. But nevertheless, you can see the overall improve in expected survival. This is the conventional way of treatment, fluid resuscitation. This is after CPFA. The survival improved significantly. Small trial, but promising result. Small trial, but improved survival. Pretty safe modality. Try or don't try, that is the question you have to ask yourself. This is what we do. Oh, this patient I've been struggling for a few days. With all the inotrope, with all the antibiotic, the CRP is still very high no matter what we do. But the moment we start CPFA, boom, 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 the CRP comes down very nicely. Another case, 40 plus. This case was from neighboring country. Did a simple ESWL. Very simple, straightforward day surgery. But lo and behold, 3 days later, admitted to ICU on Sunday. Sudden septic shock. Very bad. The BP dropped until 60, 70 plus with only with 4 inotrope. Family contacted me Sunday, 4 inotrope, blood pressure 60, 70. Bring or don't bring. Ventilated. Who will dare to bring this case? I must admit this is the most, the highest risk patient I've ever evacuated. For simple reason, if you don't do anything, he will die. I'm not saying they are no good, I'm not saying we are better. But 3 days there, no improvement, 4 inotrope, he will die. Family is aware of the risk involved. They are willing to take the risk evacuation plan. In fact, the SOS doctor asked me, are we sure we want to fly this case? Because they also scared. But no choice, in the end, we flew him, arrived in Singapore, and this is what you see. By then already, definitely acute kidney injury, creatinine high, CRP very high. Definitely a candidate for dialysis, no question asked. Only 44 years old. To give him the best chance, after all, he already paid 20,000 to fly him over here. The amount for CPFA is nothing. But the amount for the CPFA circuit, the beneficial effect may be something that others cannot offer. So during this time, rather than CPFA, we are quite lucky the Japan company came into Singapore and wanted to bring in their toromycin. Toromycin was developed by this company, Japan company, Toray. Toray is a dialysis company, but they also developed the dialyzer, the filter for gram neck sepsis. And I was told in Japan, a majority of post-op septic shock patients, this is quite a standard therapy in the ICU. They will receive 3 to 4 sessions of toromycin immunoabsorbent for suspected gram neck sepsis, especially those with intra-abdominal surgery. So quite a standard practice there. So I started it. Suddenly the Japan company called me up because I was told I was the first one to start in Southeast Asia. And they were very interested. Why was I interested? Why do we want to try this? This thing costs $2,000 for information. That dialyzer is $2,000. Why are we going to start this? Why are we using this and not the CPFA, which is about 1,000 plus? So that makes them interested. And because they're interested, I can ask for discount. So we managed to bring down the price, which is good, benefit everyone. But joke aside, more important, why I chose toromycin, because this is a intra-abdominal surgery. I mean, to me, ESWL, yeah, it's still abdominal. Definitely it's gram-negative. The result seems to be better than even CPFA. This is the mortality rate, the expected mortality rate in the trial. You can see it's a big drop, a 50-60% survival improvement, in contrast to CPFA. And I'm very sure we are dealing with gram-negative. And that's the reason why I use toromycin immunoadsorbent in this case. Now I'm going to even challenge some of my doctors. I'm even challenging the government hospital doctor. I'm in private. So private, to do such treatment, easy. Government hospital, they are also starting to be interested in immunoadsorbent for septic, but need approval. And usually, and must be done in patients with acute kidney injury. There must be kidney failure, need to do dialysis, then you do this. Because it is, in a way, a extracorporeal, a dialysis equivalent type of treatment. It is very difficult for people to change the mindset using dialysis to treat a non-kidney failure patient, which is what the apheresis group in Europe is trying to challenge. We have better survival. It is a very safe modality, just as safe as dialysis. We should roll it out in non-acute renal failure, non-acute kidney injury, septic shock patient, rather than wait for kidney failure to come in. And my experience has told me when we use such immunoadsorbent, not that it's not effective, but the later you start, the beneficial effect will not be as good as if you start early. Because you need to clear a lot of cytokines rather than early. And when you clear a lot of cytokines, the havoc has been caused for over the last few days to weeks. To reverse it takes longer. Cost goes up. Beneficial effect may not be there. Unlike you start early, you may see better beneficial effect. So that is the consensus. If you want to start CPFA or toromycin, do consider starting early. Don't wait until septic shock, very bad, then you use this as a rescue. You may find that it's not effective in most of the rescue therapy. So this is something that I want to conclude using immunoadsorbent dialysis treatment in your septic shock patient, not for kidney, more for cytokine release. The last topic that I want to talk on is on hemodynamic. I'm a nephrologist. I don't deal with the other type of machine. But what my team, or I have noticed in my team of doctors managing ICU patients over the last 2 years, besides dialysis, besides using immunoadsorbent, another modality changed the outcome of many of the patients, very sick patients, and which is what I'm going to touch on this time. Younger, 17-year-old URTI, this is from Indonesia. Admitted hospital sudden, breathless, drowsiness, BP very low, heart failure. White blood cell very low, yeah. So this is what you see on the ECG. Sorry if it's not so clear. This is the typical URTI, a fulminant viral myocarditis. In a younger, after a few days of flu, some of the virus will go to the heart, cause the myocardium to be inflamed, fulminant myocarditis. Sudden heart failure, 17-year-old. Actually, this was quite sad. The father actually passed away a few months ago from a road traffic accident. The mom only has her and another younger daughter. So they came over here. And the EF, when we did the echo on arrival, this is the EF. 9%. Global hypokinesia on multiple inotrope. So much so when she came over, she's a small sized girl, 17 years old. All you need is high dose inotrope. 1 or 2 inotrope, you will see digital gangrene appearing. So she already digital dusky, already on 3 inotrope, and this is what she has. Very bad hemodynamic. Culture, of course, negative. This is viral. But we also know viral myocarditis has very good outcome. If you can tie them over this period, they will pull through. Their heart function will go back to normal, their life is back to normal. But what else to do? That's something I want to introduce. Another case. Remember this picture? He's not fat. Later you see his original self. He is not fat. He was from a government hospital. The doctor there said after about a month ventilated there, he went for some lung operation, which we don't know what happened. Then after that, has been ventilated there for one month plus. And the lung just gets stiffer and stiffer. They have to increase the PEEP, the FiO2. And then he developed all this. Subacute emphysema from ventilator lung trauma. Ventilator-related lung trauma, high PEEP, high FiO2. And this is so-called fat is because of subacute emphysema. You press, you can feel all the crepitus under the skin. So they've been ventilated for 1 month plus. They told the family, maximum ready. You guys be prepared. We may, since not improving, we may want to wean off the ventilator. Be prepared for the worst. So desperate, they called us. And yeah, this is what you see on the x-ray. You don't need a doctor to tell you this is bad. And this is what we call a ventilator-related lung injury. High PEEP, high FiO2 prolonged. That caused the lung to be congested. Yeah, you can see very red, bleeding away. And when that happens, you need higher PEEP. You're forever chasing in a vicious cycle. And no wonder he developed subacute emphysema. No wonder they cannot remove the ventilator, wean down the ventilator. So when they called us, we work as a team. So I usually will either go down on my intensivist. Later you're going to see another surgeon will go down and access and see whether is it feasible to bring him over. When we went over to the government hospital to bring, oh shit, I shouldn't put the name here. When we went over to the government hospital and bring them over, they were, as usual, they were not happy. How come we are going to snatch the patient? They already said cannot save. But family said, I don't care, we have insurance. If that side is not doing anything, your side can do something else to give a better survivor, go ahead. So that's what we did. We went over and brought him over. The thing that changed the whole management is the use of ECMO. Familiar with ECMO? Anyone use ECMO in your ICU? Very few. So make it simply, bypass surgery, cardiac bypass. Everyone know cardiac bypass, right? During the operation, they will need to go to, the circuit. When you're operating on the heart, the circuit need to be circulated around a bypass machine. If you imagine this machine, we shrink it to very small. I mean, this is quite small already lah. If you see a bypass machine, it's much bigger than this. To a very small machine, this is ECMO. The function is exactly like a bypass machine. Portable, small thing to take over the heart, take over the lung. So this is what we did. I need to rest the lung. The lung from all this ventilator-related trauma, I need to rest it. If I tilt down ventilator, oxygen cannot. So how? That's where you use this ECMO that allow us to take over the function of the lung. Reduce the ventilator setting, the FiO2, the PEEP, to a very low level to keep him alive while we let the lung rest by applying an ECMO machine. So this is one of my surgeons, my cardiothoracic surgeon. I always warn my patient, before you see him, he looks like a butcher. He looks like, a butcher, yeah. That's what, some of the surgeon looks like butcher. That's what he looks like, but he is one of my best surgeons. When we activate him for ECMO, he will come down within 1 hour. The whole team will be there. And this is what happened to him. After a few days, I can't remember how many days, about 5 days on the ECMO, severe lung injury, which you saw last time. Now the PEEP gone down, ventilator setting gone down, the lung recovering. Very drastic improvement. Yeah, this is how it looks like. The ECMO is here. Okay, it's actually just like any dialysis circuit. You need to put the ventilator, not ventilator, you need to put the tube, the catheter, then whatever happens here, which actually consists of these few things, To most of us, it's transparent. I don't care what you use inside there, at least to me. As long as it can save my patient life, I know how to use it, good enough. And this is how it looks like. This is a venous arterial. There are two types of ECMO. One is venous, one is venous arterial. The main difference will be a venous, that means both catheter in the vein, can take over the respiratory, the lung. The venous arterial, one catheter artery, one catheter vein, will take over the cardiac as well as the lung. So that emphysematous patient is a venous. The heart is strong. We just use a VV ECMO, easier to do, less risky. The younger 17-year-old myocarditis is a VA ECMO. It's a VA ECMO. When you do such thing, when we started ECMO in ICU service years ago, there's a lot of resistance. Doctors there's two groups of doctors. I mean, don't quote me, don't bring my name out. There are two groups of doctors. One group of doctors are more challenging. They want to try new things. They believe that with new technology, new method, we can make a difference. There's another group of doctors who, gosh, I need evidence-based. I'm scared to be sued. I don't want to try this, I don't want to try that, until evidence proven. No right or wrong. I belong to this group. I want to try something new, especially in ICU. Septic shock, 50% mortality, based on evidence. We can wait for more evidence, but it's still 50%. I belong to this group. We wanted to try something new. Because you may improve survival. Until the evidence proves that I'm wrong, or maybe prove that I'm right, we should try it out. So this is what we did. When we started this ECMO in this group of patients, a lot of resistance. Some doctors, the older one, the senior one, I should not use older, the seniors one will say we are rubbish. We want to profit. We want to earn more money. A lot of resistance because ECMO has been used for heart transplant. That's the story for ECMO. A patient with end-stage heart failure, before transplant, use ECMO to support. During that time, few years ago, no such thing, use it for myocarditis, viral myocarditis, not for bridging. So many people think we are doing rubbish. Now, those senior doctors who objected have been asking us to help to support some of their ICU patients. It is now more acceptable form of practice to use ECMO in ICU critically ill patient as a bridge. It's the same story, I hope, for my immunoabsorbent. A lot of resistance there, but I hope we can progress and make it a standard treatment. Good thing about ECMO, you don't need to go OT. You can do it bedside. You activate them within half an hour, 1 hour. The whole team will come down with the machine. And you can carry out quite easily. It can be quite bloody for those who haven't seen it before. Yeah, but easily done and the bleeding can be controlled. So that fat man that you saw, this is his original self, not that Cushing look-alike. So yeah, all those fat are the sub-Q emphysema. I'm not inside there because I'm taking the picture. So this is my whole team of ICU. We work as a team. This is my cardiologist. Yeah, the handsome guy is an intensivist. This is my butcher guy. This is my infection doctor. So usually we work as a team. One of the main difference, or one of the things I learned in ICU is always work as a team. No one should be a hero. We are not so smart. I hate to say it. None of us is smart enough to take care of all aspects in ICU. Things change very fast. One person is not enough to react. So one whole team will come in. Of course, I'm not calling every time 5 people come in. We call in the relevant people. And nowadays, good thing is this WhatsApp group, the WhatsApp, form a group chat, everyone discuss the case, give the best treatment, move on. So this is my team of ICU doctor. Okay, so good, happy story ending for the young girl. She's now, I think 5 years, 5 years post myocarditis already. Yeah, last I heard she just graduated and going to get married soon. Remember, this is a family, husband passed away, daughter critically ill. If you don't do anything, the poor mom will lose both her husband and the daughter. So technology has given us this opportunity. Many people, actually young people should love technology. Your handphone, everyone is chasing for technology. But in medical, somehow I find that doctors don't like to use or fearful of technology. When they think of technology, they always think of something very high-tech, very difficult to understand. I cannot understand, I'm scared to use. And maybe because of this barrier, this inertia, we don't adopt technology that well to help our patient. We are okay with handphone. We are not okay with medical equipment, which I think there should be a mind change. Like I say, I don't care what happened in the circuit. As long as it's safe, it improves outcome, easy to use, why not embrace it? And before I end, I'll just leave you guys with this thought. That's insanity. Sorry, don't quote me again. We have been doing the same thing in ICU years and years again. Fluid challenge, inotrope, antibiotic, antibiotic, antibiotic. But we cannot admit the fact mortality is still 50%. Doing the same thing again and again, 50% of your patient will die. Imagine any one of those is your loved one. 50% will die. Now we have small trials, machines used in some developed country, approved, improved survival, of course not reach that class 1 evidence base. But we know it's safe. It can save life. It is your choice whether you want to try it out to save any of your patients. With that, I thank you all for your attention. Anyone has any question?
Okay, thank you for your sharing. Ấn tượng đầu tiên của tôi không biết có phải giống của bạn không? Không biết ông có phải bác sĩ thận không nữa? Tại vì ông nói không có giống bác sĩ thận chỗ nào hết á. Hình như ông giống bác sĩ ICU. I said to them that.
Well, but before that, understand. I hope at the end you, rather than in the end don't know what I was talking about.
Yes, I said to them that my impression that I wonder you are nephrologist or the ICU doctor because you speak look like us, not like a nephrologist here.
I think in most of your discipline, you realize you are actually crossing certain areas. Where, especially in a complex case, you will tend to cross. I don't want to fight to say that I'm an intensivist. Neither do I want to say, this is my territory, you don't come in. I think it should be a team base. It's a teamwork. Whether you call me nephrologist, intensivist, actually I just call myself, I'm a physician. I manage diabetes, hypertension, all these things. I'm a physician. Physician, I can treat anything, right? So I think that put me in a very safe term, physician.
Chắc ông nhiều job quá cho nên ông hiểu bác sĩ ICU mình. Rồi các bạn có câu hỏi gì mình cần trao đổi ở đây trực tiếp không? Yes, we have some hand.
Thank you so much for your presentation. I'm also an ICU doctor, so I want to ask you about the cytokine removal in a septic shock patient. And as you mentioned, CVFA is very good for that. But as I know that we also have a new membrane like Osiris. It's also a new absorbent membrane to remove cytokine. And besides that, it also has the heparin trap on the membrane to reduce the membrane clotting. So what do you think about when we compare CVFA and Osiris? Thank you.
So in my ICU, I use 3 systems. CPFA, Torre, and Osiris. I'm not sure whether in here, how did Gambro market Osiris? When Osiris was launched in Singapore, no mention about immunoadsorbent. They market it as something for you to use heparin-free. The circuit will not clot because it's heparin-coated. That was what it was marketed as. And because of that, many of the doctors never see the immunoabsorbent part. I agree, auxiliaries is a good immunoabsorbent. In fact, it was manufactured for immunoabsorbent. Only thing is, if you want to use auxiliaries, it's hooked onto a CRRT machine. You have to let the circuit run long. The studies have shown if you compare auxiliaries and toromycin, auxiliaries with CPFA, small study, the cytokine clearance, the first 4 to 6 hours, not auxiliaries. The other two superior, very fast clearance. Auxiliaries clearance will only come in 8 to 10 hours later. It will overtake the CPFA and the toromycin in terms of cytokine clearance. So yes, you can use it, but you need to prolong it, not just a short circuit, which also means it is heparin-free. Sometimes you still see clotting. Intermittently, if you clot it and you stop and don't restart, you will lose that cytokine removal effect. And second, to do a proper cytokine removal using auxiliaries, you must run a high volume. High volume, 2,000, 2,500, 3,000. Big volume exchange can remove more cytokine compared to 1,000, 1,500, which some of the nephrologists are doing, which totally is waste of money. So my point is, do one that you're comfortable with. If you believe in cytokine release, just stick to one, do it well, you will see the effect. I'm happy to hear that someone is using it.
Ok, chúng ta có một cái câu hỏi liên quan đến cái quả lọc Osiris. Thật ra thì đó là cái quả mà mình đang có và tôi cũng mới xài để điều trị, và chúng tôi đang có một niềm tin là cái quả đó cũng lấy được cytokine và nội độc tố. Đó. Thì hôm nay thì ông Roger ông có nói cái quả đó nó cũng không phải ngon lắm. Nè, nếu mà so đường dài, ví dụ như để lấy cytokine trong một khoảng thời gian dài 8-10 tiếng gì đó, thì có vẻ quả Osiris dùng được. Nhưng mà nói để lấy mà để tạo ra một cái hiệu quả sớm tức thì là CBFA với cái quả hấp phụ á, immunoabsorbent á, nó ngon hơn. Do chừng mấy tiếng, 24 tiếng là thấy sản phẩm rồi. Đó. Thì cái lý do mà ở thị trường của Singapore người ta nói về cái tính năng của quả Osiris chính là tập trung vào cái khả năng có cái lớp heparin nó tráng ở bên trong á, nó sẽ dùng kéo dài hơn. Còn về cái khả năng hấp phụ miễn dịch thì thấp. Tuy nhiên thì hấp phụ miễn dịch đó là immunoabsorbent, nghĩa là hấp phụ các cytokine. Còn tôi cũng nghe là Osiris thì nó có thể hấp phụ nội độc tố, không biết phải không? Thấy xài vô bệnh nhân cũng sống nhưng mà không biết chắc không, nhưng mà ông nói có vẻ cũng không hay lắm. Nếu mà chúng ta có cái CVFA và có cái toramycin gì đó thì có vẻ hay hơn. Next question.
Okay, thanks for your interesting and very helpful presentation. I'm ICU Dr. Chu, and I have one question for you because when we have patient one, can you reply the patient one?
Wow.
Yes, thank you.
Oh, you mean the kidney failure or septic shock? What?
Yes, AKI, yes.
Yeah.
Because when you speak about SLED, we have most of helpful for SLED mode, but this patient we have because they have a low platelet and prolonged ABTD. We also meet that case on the situation, and when we don't have CGS for that, and what will you do for that case? The patient have the low platelet, yes, and a prolonged ABTD because maybe the first one is maybe the heparin reaction or membrane reaction. or the complication of septic shock or something, but they have the prolonged ABGT or low platelet. And how do we figure it out? And because we don't have CChat for that. Can you? Thank you.
You are using SLED or CRRT?
Because this patient have CRRT for that.
Okay.
Yes. How can we know transfer a CRRT to SLED for very comfortable for patient? Yes.
So if they are on CRRT, and very common you will see a DIVC patient, the dilemma is always heparin. You cannot use citrate, I will still use heparin. I'm not sure here you can do the factor 10, the heparin factor, to know whether are they allergic to heparin or not. So normally when we suspect allergy to heparin or heparin-induced thrombocytopenia, we always send it off to make sure it's not there. Meanwhile, I will still use heparin, but low dose. Low dose so that it stays within the circuit. At the same time, I will also correct with FFP. You do two things together. Correct the systemic DIVC, yet you give low dose to keep the circuit ongoing. If despite all this maneuver, you still cannot have a good circuit, keep clotting, SLED is the answer. SLED, 4 hours, 6 hours, 8 hours, heparin-free, can maintain the circuit easily. The only person who don't like heparin-free, your nurses. Your nurses every half hourly need to flush the circuit. It's quite labor intensive. But if you cannot maintain a CRRT machine, circuit, SLED, intermittent, heparin-free will be the answer. But on a daily basis. Hope that helps in your question.
Okay, thank you. But if the patient have CRRT,
Yeah.
but have a problem about thrombolysis, do we want to change for SLED mode? How can we change to safe patient or something? Because the patient have the stable hemodynamic after treatment.
Yeah, so if your CRRT cannot maintain because of bleeding, you're worried of bleeding, no matter what you do, you can, like I said, you can add a bit of heparin, you can give FFP. You're still worried or there is bleeding, stop CRRT. Do SLED, heparin-free. You already said hemodynamic very stable, so you're not worried of BP. 4 hours, 6 hours heparin-free, very easy to do. Just don't like, but easy to maintain. You can achieve your clearance without worry or fear of bleeding.
Trong lúc lọc máu á, chúng ta luôn có một cái khó khăn, đó là cái chuyện chống đông. Thì dĩ nhiên thì làm càng trễ thì cái khả năng đông máu của bệnh nhân càng lớn. Đó là cái rắc rối của chúng mình. Cho nên là nếu mà mình nghe ổng đi, làm sớm chút xíu nó sẽ đỡ bị cái này. Còn nếu mà mình vẫn làm trễ thì bây giờ cái vấn đề giải quyết như thế nào? Thì ổng có khá nhiều giải pháp. Giải pháp thứ nhất đó là dùng CChat, đó là quá ngon rồi. Tôi cũng không hiểu tại sao mình cũng không có CChat nữa. Đó là điều tôi cũng chưa hiểu, nhưng mà ông có. Thì đó là cái tốt nhất. Làm sao mà mình cố gắng mình hợp với nhau lại, mình sao mình đề nghị được cái CChat á, thì mình sẽ giải quyết được bài toán đó. Còn cách thứ hai đó là mình phải cho heparin liều thấp, heparin liều thấp. Đó. Nhưng mà cái khó là heparin liều thấp làm sao mà cân bằng được giữa cái nhu cầu chống đông với cái nguy cơ chảy máu, là cũng khó. Cái cách thứ ba đó là thay vì chạy CRT phải dùng chống đông liều thấp thì mình có thể dùng SLED. SLED có nghĩa là một cái mode trung gian giữa thẩm phân lọc máu ngắt quãng với lọc máu liên tục. Đó là mode trung gian. Cái thời gian nó sẽ cũng trung gian luôn. Một cái thì 24 tiếng, một cái 4 tiếng, thì cái này khúc giữa 6 đến 8 tiếng. Rồi cũng trung gian mọi thứ, kể cả heparin, nó có thể cho phép chạy không heparin. Nghĩa là 6 đến 8 tiếng xong cái mình ngưng. Mình không chạy nữa. Trong 6-8 tiếng mình không có chạy heparin. Rồi sau đó thì cái người mà ghét nhất cái mốt này, ông có nói là nurse ghét cái mốt này lắm. Tại vì chạy xong á, nurse phải đi rửa cái quả lọc đó để mai chạy tiếp. Rửa đi cho nên là nurse ghét. Còn CRT chạy xong dục luôn nó cũng đỡ. Đó là những giải pháp của ổng. Rồi các bạn có ý kiến gì thêm không?
Before we proceed, so in here, in ICU, who ordered the dialysis? Is it the intensivist or the nephrologist? Intensivist. So the intensivist is the king of everything.
Because that's why I say that our impression now that you are the nephrologist or intensivist, because the nephrologist don't care about the CRT or renal replacement in the ICU.
Okay.
Nhờ anh Trường translate cho em cái này, cái ý nó hơi dài. Thì gần đây bên Nguyễn Chi Phương em cũng bắt đầu tiến hành lọc hấp phụ. Nhưng mà cái vấn đề khi mà đọc y văn tham khảo lại thì cái vấn đề lọc hấp phụ sẽ lấy cơn bão, lấy cytokine ở những bệnh nhân mà có cơn bão cytokine thì mình lọc bao nhiêu lâu, bao nhiêu lần, và khi nào mà mình thấy quyết định là mình ngưng cái quả lọc hấp phụ ở đi, mình chuyển sang những biện pháp thận thay thế thông thường thôi. Gần đây thì mình có đọc trên y văn thì bởi vì cái dược động học của cytokine ở trong những bệnh nhân mà có cơn bão cytokine nó tới giờ này người ta vẫn chưa có hiểu rõ. Tức là người ta thấy là sau khi mà đọc một lần lọc hấp phụ rồi thì giống như là có hiện tượng rebound cái nồng độ cytokine lại. Thì cái vấn đề đó trên lâm sàng thì người ta thấy có mối tương quan giữa cái nồng độ cytokine với cái calcitonin trong máu. Thì người ta có thể sử dụng cái nồng độ cytokine đó, check cái nồng độ cytokine đó để quyết định có theo dõi thôi, một cái biện pháp theo dõi cái đáp ứng của cái việc lấy cái cytokine đó ra. Thì trên thực tế thì hỏi giáo sư thì thực tế là khi mình trên lâm sàng mình sử dụng cái biện pháp nào để đánh giá cái hiệu quả của việc lọc lấy cái cytokine đó ra là nó hiệu quả, và thời điểm nào là mình ngưng, và mình trên lâm sàng mình có những cái biện pháp nào để theo dõi cái hiện tượng rebound cytokine đó hay không?
So now this is the long question.
Yeah, I know.
ICU doctor. He work in the class 1 hospital in Ho Chi Minh City. He just applied the hemoperfusion in his ICU. Now he has some question. When the mechanism, because of the mechanism of the cytokine storm is very complicated. When do the cytokine removal by hemoperfusion or by CBFA or by many things, how can evaluate the effectiveness of this method, and how to monitor the marker of the cytokine storm? Yeah.
The mechanism itself, I actually put it quite simply: bacteria, cytokine, and organ damage. What type of cytokines? All these are, to me, they are only theory. We group it under cytokine. That's all you need to remember, because I'm not an immunologist. I'm not academic. All I know is cytokine causing problem, which is what, as a physician, you guys will be faced with. How it works, you just remove cytokine. Need to monitor, what to monitor? You can monitor a lot of markers, which is not going to change your management. Expensive, and many labs, they only do it for research, not for clinical. The only marker that I find it, two markers that easy to use for you to monitor: CRP. CRP, the inflammatory marker will come down. You saw it just now, within 48 hours, the CRP dropped. Pro-BNP, another inflammatory markers you can use. Okay, so these are the markers that, procalcitonin, sorry, I beg your pardon, procalcitonin. Yeah, so we have procalcitonin in Singapore. These two markers, you can use it to monitor. Does it change your management? Answer is no. In fact, I don't monitor them anymore. Once I start the circuit, based on my studies, easily is 3-4 cycle. I'm not monitoring the markers anymore. I'm monitoring the clinical outcome. FiO2, inotropic support, all must improve. Then I don't care what is the marker. Endpoint improve, yes, it has contributed. I will not take full credit, CPFA make it improve. But most important, outcome must improve. So I don't monitor those anymore. For a start, I did it to prove to people it works, but now I don't anymore. It adds on to the cost, and it will not change the management. 1 cycle, 2 cycles, CPFA, auxiliaries, doromycin is not effective enough. You bring it down, it will go up again. So 1-2 days is not enough. That's why in Japan, it's easily 3-4 sessions, a standard therapy. So look at the clinical.
Ok, ông trả lời, ông đã cũng từng làm nghiên cứu rồi. Nói một cách dễ hiểu, thì khi một cái sepsis do một cái nhiễm trùng, nó sẽ gây ra một cái dòng thác cytokine. Cái dòng thác đó sẽ làm tổn thương cơ quan. Thì ông đã từng cố gắng chứng minh bằng những cái marker. Tuy nhiên, chứng minh xong rồi thì cũng khó thay đổi được điều trị. Tại vì sao biết marker nào xấu hay tốt như thế nào cũng rất là khó nói. Nhưng cái lâm sàng thì nó lại dễ hơn. Thì khi mà dùng cái kỹ thuật đó thì ông hay dùng là cho chạy khoảng chừng 3-4 lần thôi. 3-4 lần chạy CVFA đó. Thì sau đó sẽ quan sát cái hiệu quả lên các chức năng cơ quan. Ví dụ như là cái thay đổi của chỉ số oxy hóa máu, thay đổi cái liều thuốc vận mạch, rồi các cái marker viêm thông thường mà chúng ta đang dùng hàng ngày đó. Ví dụ như nãy bác sĩ Kim có đề cập mà tôi quên nói, đó là cái procalcitonin, may sao ông nói luôn. Procalcitonin, có CRP, có PNP. Đó là những cái marker thể hiện cái chức năng cơ quan. Khi chúng ta làm mà các marker nó tốt lên, lâm sàng tốt lên là được rồi, là được rồi. Đó. Chứ còn các interleukin gì á, nói cho vui cho nguy hiểm vậy thôi, chỉ dùng trong nghiên cứu là chính.
Thank you for your presentation. I'm a pediatric ICU doctor. I have a question for you. In the patient with the septic shock, if you go to the CRRT, not because the kidney failure, do you need to adjust the antibiotic dose? Do you need to increase the antibiotic dose or reduce this?
So once you start CRRT, you have to increase the doses of the antibiotic. That's definite. Almost all antibiotic need to be cleared by the renal. So once you increase it, the dose, most of the time, easy formula double. Example, meropenem before dialysis, 500 milligram BD, 12 hourly. Once you start CRRT, it will be 1 gram. It will be 1 gram. So most of the antibiotic, you need to increase the dose. Increase the dose of antibiotic. Usually double. Usually it's double. Easy formula to remember.
Does it depend on the size of molecular of antibiotic?
Yeah, so most of them will need to increase. Most of them. The common one that you use will have to increase. The newer one is through hepatic, maybe not. But most of the common one, you will have to increase once you start CRRT. Same thing, when you stop the CRRT, remember to cut down the dose. Increasing, I'm not too worried. It's stopping it or cutting down when you stop. Some doctors forget. And then even a simple penicillin, a meropenem will run into side effect. You will run into side effect if you forget to tail down.
So some drugs, some antibiotic drugs have the bad side in the renal function, like vancomycin. So when you double the dose, do you scare about it?
So in kidney, let's say before dialysis patient, the vancomycin, for example, what I normally give is 1 gram every 3 to 4 days. But once you start CRRT, I will 1 gram every 48 hours. But more important, monitor the trough. Because not all patients are the same. Good thing is we can measure the trough to guide us on the toxicity and the therapeutic range. So not just the frequency, more important, monitor the trough. Example for Vanco.
But some drugs you can do the test to monitor the drug, the level in the blood.
So some you can, some you cannot. Those you can, please monitor it. Because it may not be all 48 hours or 72 hours. Some patients just react differently. If you can, you have to monitor. But most antibiotic, the dose need to be increased when they're on CRRT.
So in your clinic, do you measure on the level of the antibiotic during the CRT?
No. If anything, it's only Vanco. That's the only one that I monitor. I don't monitor aminoglycoside because I don't use it. They're already kidney gone. No reason for me to use aminoglycoside. Meropenem, research purpose, I don't. The penem group, I don't. The newer one, they claim don't need to monitor. So I also never. So if anything, it's a Vanco.
Cái câu trả lời này trả lời cho riêng cho bác sĩ Hiệp một chút. Chắc là nhờ anh Quang anh Trường translate lại cho. Tại vì vậy nè, khi các bạn chạy CRT thì bác sĩ Roger Tân thì tức là đồng ý về cái chuyện mà tăng kháng sinh. Nhưng mà thật sự tăng khi nào và tăng bao nhiêu? Dựa vào cái gì? Thứ nhất, các bạn chạy CRT vì suy thận, các bạn không đánh giá được cái chức năng thận còn lại là như thế nào nha. Khả năng thanh thải cái thuốc đó qua màng CRT là như thế nào các bạn cũng unknown luôn. Như vậy thì mình hơi confuse cái chuyện mà tăng ha. Chắc có lẽ là mình nên theo cái policy, cái guideline của khoa đi nha, chứ mình không nên tức là tự ý và suy nghĩ thì nó không nên. Mình theo cái guideline của khoa thì nó tốt hơn. Là tại vì mình rất nhiều biến unknown trong đó. Thì suy nghĩ của tôi là như vậy nha.
So a lot of have many comments about the antibiotic using during the CRT. So I think that this is a big topic because on the innovation with that machine, there are a lot of factor effect on the level of the antibiotic. We cannot know exactly level, so to adjust that, they say that should follow the policy of the ICU department. They have their own protocol for that. Okay. Chắc mình có một số câu hỏi online. We have some online question. Câu thứ nhất thì cũng dính dáng đến kháng sinh. Chắc hỏi câu 2 trước đi nha. We have a online question. There is one case diagnosed of the malaria infection and was put on the artesunate treatment. So for that kind of medication, do we need the adjustment for the dose?
I must confess, I am not an expert in malaria, so I can't really, but there's always a Mr. Google for me to check. So I really don't have the answer. I will Google first and get the ID doctor to help.
Một điều may mắn cho ông là ông ở cái nơi mà nó cũng không có nhiều sốt rét. Đó là cái tôi nghĩ, tại vì ông nói ông không phải là chuyên gia về sốt rét, mình chuyên gia hơn. Chắc là ông sẽ hỏi mình là chính chứ không phải là mình hỏi ông đâu. Chắc là hỏi câu khác đi ha. Các bạn còn câu hỏi gì nữa không? You work at the kidney clinic, so you use the CRT for the patient in your clinic every day?
No, in ICU.
You have ICU in that clinic?
In the hospital.
Hospital.
So in say example, Mount Elizabeth, this is a hospital. Our clinic is the medical center next to the hospital. We admit patient into the hospital. We go over there to see patient. We cannot do CRRT or ICU in my clinic. No way, no way.
Because you know a lot about the CRT, but on the first slide you said that you work in the kidney clinic.
Yeah. So that's my clinic. That's my clinic. I also run a group of dialysis center outside hospital. So that is separate.
Yeah, I have a question about in the septic shock patient with AKI. Yes, I think in the routine clinical practice, I saw some doctor use the furosemide to maintain the urine output before they start dialysis or CRT. So what do you think about that? Yeah, thank you.
I think all this furosemide, bicarbonate, all this has been attempted because people don't want to start dialysis. Or many are fearful of dialysis. Maybe patients, relative, wow, when you say dialysis, everyone think of is very serious. Doctor, start dialysis, I need to do this, I need to do that, there's risk involved. So many attempt to use medical therapy to delay dialysis. Not wrong. I will sometimes do that too. I will do that too, because sometimes family need time to digest. And the correct way to, my own way of doing it, if fluid is a problem, furosemide, any form of diuretic you can use. But you must set a time frame. 12 hours, 24 hours, 48 hours. You must have this time frame there right from day one where yourself communicate with the family. If after that period it is not working, please start. Because for those who run ICU, we always have this problem. You see the patient every day. You see them 3 times a day, 4 times a day. Sometimes a creatinine, for example, a creatinine 1.1, tomorrow 1.3, next day 1.5. Every day is a small increment. Many times no big deal compared to yesterday. Just go out a little. Just go out a little. But if forgotten from day one, it has actually gone up a lot. By seeing regular, we don't appreciate this small change. And then we delay treatment. Same thing when you give diuretic, today you give. Tomorrow urine from 20 become 30. Yeah, improve. Let's wait. 30, 20. Yeah, still the same, 20 as 20 before. And we just delay and delay. You don't have that sense of urgency anymore because we see patient every day. And then we just, okay, carry on. But the studies have shown high dose diuretic actually increase mortality. So you can give it a try, set a time frame, 24, 48 hours. Usually my maximum is 48 hours. Especially it's over the weekend. Okay, I put it, practical terms. If the doctor call you in Friday night, You tell the family, I want to do dialysis. Cost is an issue because everything at night, I'm not sure here in Singapore there is a surcharge. There is a surcharge. So I will try not to do dialysis at night unless very urgent. Next day, Saturday, too short for family to understand the seriousness. So sometimes if it's stable, I'll tell them 48 hours, Monday, then we decide. But if it's a weekday, I normally 24 hours. If I give diuretic, and please give high dose. If someone has AKI, creatinine 2 point something, 3 point something, 40 milligrams is not going to touch. It's probably going to touch the capsule of the kidney. It doesn't touch the cells, the tubular at all. So you want to give whack in high dose, 120 and above, TDS. If it's going to work, it will work. Which also means it's not going to work, no point continue. Or if you're daring, infusion, 10, 20, 30 milligrams per hour, 24 hours. Not working, not working. Don't add on a second diuretic. It's not going to work.
Thì cái câu hỏi mà ngay từ cái mấy slide đầu của nó rồi, khi nào để mà bắt đầu một cái liệu pháp thay thế thận, thực ra là đến giờ này nó cũng không có một cái điểm cắt nào hết, điều đó đương nhiên, và cũng không thể nào nói là bắt đầu sớm hay trễ thì cái nào tốt hơn, ông không thể kết luận được chuyện đó, mà ông theo cái nhóm bắt đầu, ông đặt ông vào cái nhóm đó. Thật ra tôi cũng nằm trong nhóm đó. Thì trước khi khởi động một cái liệu pháp thay thế thận thì các bác sĩ có thể thử các biện pháp điều trị khác, ví dụ như dùng thuốc lợi tiểu, dùng bicarbonate, thì điều đó là hợp lý. Ông cũng nói điều đó là hợp lý. Chúng ta có thể tăng liều lên. Tất nhiên thì chúng ta sẽ xác định một cái thời gian. Ví dụ như khi chúng ta bắt đầu cái biện pháp nỗ lực đó thì chúng ta phải cho một cái điểm mốc. Nếu mà thất bại thì chúng ta sẽ bắt đầu liệu pháp thay thế thận. Đó là cái quan điểm của ông. Rồi cái câu hỏi online hỏi về giá của cái chạy thận của bên ổng, chắc tôi cũng sẽ hỏi. Can you tell us one online question from the Facebooker? How much does it cost for the one session of the dialysis in Singapore?
What type of dialysis?
Intermittent dialysis.
So if we're looking at in ICU, intermittent dialysis in ICU in Singapore, you first must remember Singapore, everything is expensive. One bottle of mineral water is usually $2. So with that in mind, you can see the price difference. So a standard dialysis in ICU, a standard one, 600 to 800. When we talk about CRRT, almost 2K, 2,000. That will at least tell you how expensive things are. But having said that, if you're looking at an ICU patient where every day once they're ventilated, the cost can be easily 8K or so. But putting in 1-2K may change the outcome. I personally feel that it's worth it to give it a try.
Nói chung giá của ông cũng bằng mình thôi, 600 đến 800. Nhưng mà ông là đô, mình là ngàn. Cũng tương tự. Còn lọc máu cũng tương đương. Ông cũng 2.000, mình cũng xem đó.
Can I ask question? I can see a lot of you are definitely majority are younger than me. Who are the ICU doctor here?
Almost.
Oh, and I understand the ICU runs everything. From antibiotic to dialysis to ventilator, almost everything. My question to you, why you want to choose such a stressful job? You are the only person determining someone's life and you have no one else to help. It is very stressful and you're still young. Why not you choose an ophthalmology? Huh? Teamwork, okay.
Tại sao các bạn chọn ICU mà làm khi mà khổ dữ vậy?
Because I think in my hospital, when I work in ICU department, even though the workload is kind of pressure, but we work as a team. So it's also, bring us still motivation to keep going our work. And I think sometimes the ICU doctor also has a special characteristic to be in that field. So
It's tough. All I can say, ICU doctor tough.
Is there one question I don't understand?
Oh, if you don't understand, I also will
No,
not.
yes. The question mentioned about the dialysis chair. It means that the patient was put on the chair during the dialysis, and he want to ask the cost, the price of this chair.
Okay, this chair has nothing to do with ICU. For those who are not nephrologists, who are not
For chronic kidney.
yeah, so we are looking at chronic in the dialysis center outside. Patient is comfortable, well, walk around, go there, sit down there. What is the cost? Depends on how much you want to pay. It can be from a simple reclinable sofa to the high-tech $5,000 dialysis chair. So depends on your brand. I mean, I run dialysis center. If I'm going to do dialysis in a heartland, most people, they are general people, they are not going to pay so much, they have cost problem. You're not going to buy a $5,000 chair. A simple chair, safe, comfortable, proven, is good enough. So it can be as cheap as few $100s to $5,000.
Tại vì cái anh này anh muốn mở một cái trung tâm chạy thận rất là lớn và hiện đại, nên chắc là tôi sẽ đưa giá 5.000 cho cái ghế này. Cái anh bác sĩ Thịnh anh đang hỏi.
There are some dialysis chair that come with massage one. Yeah, if you want a better one, you can do that.
So this is the first time you join with us. Can you share your impression and comment about this coffee talk?
No, I think this is very interesting to me. Most of the time it's in a boring lecture room or in a hotel room. This is, I think it's more relaxing. You can interact more. It's not like I'm teaching. It's more of you guys sharing ideas. And I think, nothing against senior doctors, I think it's good to start with the younger generation. Because we may be able, I don't consider myself young anymore, you guys may be able to make changes. And changes always come with an idea. It's good to expose new ideas to you guys, to younger generation, for you guys to think through and wait for further evidence to carry on from there. If not, things will still be the same. That's what I always tell people.
So are you willing to bring your team to Vietnam?
They are the bosses.
Manager, a lady, we have the powerful lady here. Please come to the stage. Giới thiệu các bạn là chị Linh, người phụ nữ quyền lực.
Xin chào tất cả các bạn. Thực ra thì mình không phải là người phụ nữ quyền lực. Mình chỉ là người phụ nữ đứng sau tất cả những người bác sĩ như thế này. Mình là trưởng đại diện của tập đoàn y tế Quốc Huy Singapore tại Việt Nam. Đứng đằng sau các bác sĩ, chăm sóc các bác sĩ, đưa các bác sĩ sang bên này, đưa đi ăn, đưa đi chơi, đưa đi uống bia. Thế còn lại công việc thì làm thì sẽ nhờ bác sĩ Trường, chứ mình không có làm gì cả. Thế nên là mọi người có muốn hỏi về bác sĩ Singapore, muốn đi chữa bệnh ở Singapore thì hỏi mình. Còn nếu hỏi công việc thì chắc lại nhờ bác sĩ Trường trả lời.
Dạ, câu hỏi công việc cái gì? Hồi nãy hỏi công việc thôi, chị hiểu nhầm đấy. Có nghĩa là lần sau chị có sẵn lòng để thỏa mãn tất cả các bạn ở đây. Thứ nhất là mời các chuyên gia của Singapore qua chia sẻ kiến thức.
Chị lại nghĩ cái mỗi câu đằng trước là có sẵn lòng làm thỏa mãn các bạn ở đây không? Cái câu đấy cũng hơi chắc cái câu đấy thì cũng khó trả lời đúng không? Thực ra thì là sau khi mà mình thấy các bạn đến đây rồi cái cách mà bên Cà phê Hồi Sức làm thì mình nghĩ rằng là có lẽ là phải đến nhiều hơn. Thế nếu như mà có thể được thì mình cũng vừa nói chuyện với sếp của mình xong là nếu mà vậy thì anh xem tình hình như thế này thì có thể từ giờ đến cuối năm em sắp thêm 2 bác sĩ nữa qua. Thế là để thành một cái section tiếp theo, bởi vì thấy mọi người nói đến bác sĩ thận trong ICU, mọi người nói đến bác sĩ tim mạch trong ICU, mọi người nói đến bác sĩ thần kinh, đúng không? Kiểm soát về cái gì đấy như tối qua mình nói đó, đúng không? Là
về thì các lĩnh vực liên quan đến theo dõi điện não trong ICU, đó là chủ đề.
Không dám hứa trước, nhưng mà sẽ cố gắng thu xếp từ giờ đến cuối năm, mà có thể được thì sẽ full fill được ít nhất là 2 bác sĩ nữa để cover cái phần mà bác sĩ Trường. Thực ra đây là cover cái thỏa mãn em chứ không phải là thỏa mãn các bác sĩ khác. Xin cảm ơn mọi người.
Rồi chúng ta hoan nghênh ghi nhận cái
Oh, thank you. Just now, I believe she said something good.
yes, very good.
I couldn't understand what she
Chúng ta còn câu hỏi gì đâu mà? Dạ.
Đồng nghiệp của anh hỏi nữa.
I think we take the last 1-2 question, then everyone can go and enjoy their Sunday.
The last question. I will speak the exactly sentence question. As you know, some of the dialysis machine do not monitor pH of the dialysis coming out from the machine. In this case, do you check pH of the dialysis? If yes, how often?
The question is pertaining to whether is it ICU or daily outpatient dialysis. So there is a difference there. If you're looking at chronic kidney disease in a
Chronic.
stable outpatient basis, we don't monitor the pH every session. Every weekly, we will do the biochem of every machine, sent to the lab and then certified. Not just pH, calcium, potassium, sodium, bacterial count on a weekly basis. All this is done regularly, and this has to be checked by ministry very often.
Thỏa mãn chưa anh? Mỗi tuần làm một lần mà làm nguyên full. Yeah. He looks satisfied. Rồi, nếu mà chắc là hết câu hỏi rồi đó, thì chắc buổi hôm nay chúng ta sẽ kết thúc ở đây. Chúng ta có rất nhiều cái sự tương tác rất là vui, và chúng tôi hy vọng thì lần tới sẽ có nhiều chuyên gia đến đây nữa chia sẻ kiến thức với chúng ta, và tôi nghĩ chúng ta sẽ học được rất nhiều từ họ. Thank you once again.
Thank you.
Take a picture, a photo.